Hey guys, welcome back to my channel, The ENT Resident. Today I'll be talking about how to take an history in the case of oral cavity, larynx, and pharynx. Previously, I have already taught you about history taking in an ear case and a nose case. This will finally wrap it up in terms of history taking in ENT. So let's start with the patient particulars first. So first thing, this will be a little repetitive. I have talked about this in the previous two videos. The importance of taking name of the patient is there are three important points here. First of all, it helps you in identifying the patient. Secondly, it will help you in developing a good rapport with the patient when you are on a name basis with each other. And thirdly, it's very important for maintaining records for the hospital. Next, moving on to age. Now, how does age play an important role in finding out what case you might have? What is the diagnosis of the case? So, there are certain cases which happen in young children, in adolescents. There are certain cases which happens in the adults. There are certain cases which happens in elderly. So, I've just given a few examples for you to have an idea of it. In young children and infants, you'll see oral thrush or candidiasis happening more often, even acute epiglottitis. Whereas in adolescents, you'll see more recurrent cases of tonsillitis coming to you for tonsillectomy, then recurrent respiratory papillomatosis, and mononucleosis. And this is something everybody knows malignancy is more common in elderlies. So, this is the importance of age in history taking here. Next, we move on to sex or the gender of the patient, the biological gender of the patient. Coming to males and females, there are certain diseases that are more common in males, and there are certain diseases which is more common in females. You'll be hearing that malignancy is more common in males because of habits like smoking, gutka, tobacco chewing, alcohol. Whereas there is one carcinoma which is more commonly found in females in relation to the throat here, and that is post cricoid carcinoma. You will see this carcinoma happening more commonly in females who are iron deficient. So, the diseases that are more common in males here are oral cancer, the carcinoma of larynx, leukoplakia, which is a pre-malignant condition where you find a whitish patch in the cavity, oral cavity, or anywhere in the throat. And in females, post-cricoid carcinoma is very common. Next, we move on to the address of the patient or where this patient geographically belongs from. There are certain diseases like which is common in certain areas. Like for example, laryngeal tuberculosis is more commonly seen in West Bengal, Bihar, Uttar Pradesh. Goiter will be most common in the Himalayan region where there's iodine deficient areas like Uttarakhand, Himachal Pradesh, northeastern India. That is where goiter is more common. Oral precancerous lesions like leukoplakia, erythroplakia, these will be common more in central and southern India. And Plummer-Vinson syndrome is seen more commonly in Gujarat. So sometimes this is not very specific, but the address may make you aware of certain diseases that are more prevalent in those areas, and that will help you in reaching a diagnosis over there. Next, we move on to the occupation of the patient. How is occupation important? There's a lot of, when you're taking a history and a patient presents to you with a chief complaint, for example, say somebody comes to you with a hoarseness of voice, which is consistent, you will have to ask the history of if there is any history of vocal abuse. And there are certain occupations that you'll see that vocal abuse is very common in. For example, like teachers, singers, hawkers. These are all people who talk in a loud voice in an unregulated manner, which overuse of the voice in the wrong manner can lead to certain lesions like vocal nodules, vocal polyps. So, occupation is very important. And so, other examples would be like laryngocele is seen more commonly in trumpet blowers and glass workers. Vocal nodule is something I have already mentioned. Oral cancer is seen more commonly in agricultural workers, factory workers. Laryngeal cancer is more commonly seen in the welders, construction workers, and workers who are exposed to asbestos. So, this is about the importance of occupation in history taking. Now we move on to the main part, which is the chief complaints. What are the complaints that a patient comes to you with? So there will be a few complaints which end up forming the chief complaint, and then there are some associated symptoms which is something that adds up to the diagnosis. We'll be discussing each one of them. So, the primary chief complaints in such cases are change in voice, difficulty in breathing, noisy breathing, cough, difficulty in swallowing, pain while swallowing, disturbance in taste, and altered speech. You'll notice that I have mentioned here difficulty in swallowing and pain while swallowing instead of using the medical terms like dysphagia and odynophagia. So the prime thing to remember here is the history is always taken in terms of the patient's language. It is not written in medical terms. So, a patient will never come to you and say that I have dysphagia or odynophagia. So, if you ever end up writing those terms when you're taking your history and you present to your examiner, you will definitely lose a lot of marks over there. History is always meant to be taken in the patient's own language. So, always describe what the patient is saying and write it down. So, next are the associated symptoms. So, associated symptoms can be a lot of things like swelling, a foreign body sensation and throat clearing, nasal regurgitation, disturbance in salivation, ulceration, difficulty in opening the mouth, bad breath, mouth breathing and snoring, hearing loss, lump in the throat, lump in the neck, paresthesia or anesthesia of area of a cheek lateral to midline. So these are generally roughly all the complaints that you may encounter in a case of oral involving the oral cavity, pharynx, or the larynx. Now I'll be discussing each one of these complaints in a little bit more details. So moving on to the history of present illness. First complaint I'll be describing is change in voice. Now, whenever a patient comes to you with a change in voice, the first thing you ask is the onset of it. It can have a gradual onset or a very sudden onset. The duration for which it has been present, how has it been progressing? Has it been rapidly progressing and worsening, or is it the same continuously? And then a very important part is to know what is the character in this change in voice. There can be a lot of different types of voice changes. So I'll tell you a few of those voice changes that you may encounter and small examples of what it might be. So the most common type of change in voice that you face is a hoarse voice. And a hoarse voice usually happens due to a disturbance of the normal wave pattern of vocal cord. What are some examples where you might see this? For example, I was just telling you about vocal nodule and vocal polyp in people like people with the occupation of a teacher or a singer or somebody who is in public speaking. So what happens is a vocal nodule or a polyp forms in the vocal cord and it disturbs the normal wave pattern of the vocal cord, which leads to a hoarseness of the voice. Second is a husky or a breathy voice. This happens due to a paralysis of the superior laryngeal nerve, and this superior laryngeal nerve supplies the cricothyroid muscle. This will be seen in cases of vocal fold paralysis. It can also be associated with bovine cough. Third one is a hot potato voice. This is also known as a muffled voice. This happens due to involvement of the supraglottis and the base of the tongue. And why do you call it a hot potato voice? It's called a hot potato voice because it sounds exactly like if you put a hot potato in your mouth and you try to speak, the kind of voice that will come out, that is what is known as the hot potato voice. And this will be seen in cases of growth involving the base of tongue, the epiglottis, and the supraglottis. Next is a whispering voice. Whispering voice is something you will see more commonly in functional or psychological patients where there's actually no structural difficulty, it's more a functional difficulty. Next is a feeble voice. Feeble voice is also known as asthenophonia. This can be seen in tuberculosis and emphysema. This happens because the expiratory air is not strong enough to vibrate the vocal cords, as a result of which the voice becomes very weak. You can barely hear it. Next is puberphonia. Puberphonia is a persistence of a childlike voice even in adulthood, and this is seen more commonly in some endocrinal cases. Last characteristic is aphonia, which basically is it can develop gradually, in which case it is preceded by a prolonged period of hoarseness, like in TB laryngitis. What happens here that there is no voice at all coming out of the patient. This is known as aphonia. This can be seen in TB laryngitis. It can also be a functional aphonia, where there's actually no structural problem at all. It can also be seen in acute cases of laryngitis. So, you have asked about the characteristic of the change in voice. Next, you gotta ask whether this change in voice is constant or intermittent in nature. As I was just saying, vocal nodule or vocal polyp, these are structural problems in the vocal cord. These will be constant throughout the day. Whereas a inflammatory case like a case of chronic laryngitis, you will see that this becomes more worse in the morning, whereas in the evening it is way better. And the reason behind this is at night there is decreased swallowing. This leads to more aggravation of the change in voice when you wake up in the morning. So, this is how it helps you in differentiating between constant and intermittent nature. Next is diurnal variation. Does it become worse in the morning? Does it become worse in the evening? Or how does it change as the day passes? These are all factors which will help you to point towards certain diagnosis. Like I just said, chronic laryngitis gets worse in the morning, whereas the conditions which get worse in the evening are malignancy and vocal cord palsy. Conditions which worsens as the day passes, like vocal nodule and vocal polyp. As you keep speaking throughout the day, it keeps getting worse. But with more rest in the voice, the condition starts to become a little better, which is why one of the most important management in this, when a person comes with a very tiny nodule, where you give conservative management and you tell the patient to not use their voice for a while, and whenever they do use the voice, to use it very lightly. And there are certain conditions which improve as the day passes. For example, Rinke's edema is one such case. Next, you ask, are there certain habits involved, like excessive talking or loud talking or singing, excessive smoking? Smoking, you'll see, like Rinke's edema cases are more commonly seen in smokers. Is there a history of alcohol consumption here? These are all points that will help you in understand which disease it might be. And occupation the same: teacher, singer, hawker, exposure to irritants like dust, fumes. Is there any aggravating or relieving factors? So, these are all the points that you need to ask when it comes to change in voice. Now, I'll just talk a little bit about what are the causes of change in voice. This is not an extensive list, but it's just to help you form in your mind what type of disease it could be and what are the different examples under a certain type. So, these can be inflammatory disorders, structural disorders, paralytic disorders, neuromuscular causes, and muscle tension dysphonia. So, inflammatory disorder can be infective and non infective. Example of an infective one is chronic laryngitis, and a non infective one is arytenoid granuloma. Example of structural disorders would be vocal fold polyp, vocal nodule, Rinke's enema, cyst, sulci, mucosal bridges, benign and malignant tumors. Paralytic one, the example is vocal fold paralysis, where there can be involvement of the superior laryngeal nerve or the recurrent laryngeal nerve. Neuromuscular causes are where abductor and adductor dysphonia happens secondary to another neuro cause like Parkinson's disease, multiple sclerosis, myasthenia gravis, and motor neuron disease. And tension dysphonia is a condition where you see there is an imbalance of the synergist and the antagonist muscles of larynx. So, this is like a short list of causes of a change in voice, something that you can keep in mind when you take the history of a patient. Next, we move on to the second chief complaint, which is difficulty in breathing, also known as dyspnea in medical terms. You ask whether it is a sudden onset or an insidious onset, how long has it been present for, How is it progressing? Is it gradually, very slowly progressing, or is it rapidly progressing, or is it leading to noisy breathing? What are the variations? Like, does it change throughout the day and night, or is it constant? Is it present during activity, or is it present also at rest? Is there any variation with position, like, say, for instance, sitting, standing, supine, walking? Is there any variation at all? And what are the aggravating and relieving factors? And when somebody describes to you that they are having difficulty in breathing, there is a grade that you can put it under. Grade 1 is when there is breathlessness on very strenuous activity like exercise or running. Grade 2 is when there is breathlessness on doing more than accustomed work, like climbing stairs or hurrying on a level ground. Grade 3 is where there is breathlessness on doing less than accustomed work. This can be seen in normal pace walking. And grade 4 can be seen when there is breathlessness right at rest. You're not doing any kind of movement, you're not walking, but yet you're having difficulty in breathing. This is how you classify shortness of breath into 4 grades. Next, we move on to the causes of dyspnea. The cause of dyspnea can be at different levels. It can be at the level of pharynx, it can be at the level of larynx, or it can be at the level of the tracheobronchial tree. Some examples are, if it is at the level of pharynx, it can be due to a abscess. The abscess can be in the peritonsillar area, the parapharyngeal area, retropharyngeal area, in the tongue. There could be a lingual goiter or any malignancy. Examples of causes of dyspnea in the larynx would be laryngomalacia, acute epiglottitis, croup or acute laryngotracheobronchitis, glottic edema, vocal cord paralysis, laryngeal spasm, diphtheria, foreign body trauma, benign lesions, laryngocele, and malignant growth. And causes at the level of tracheobronchial tree are foreign body tracheal injury, tracheal stenosis, external compression, tracheomalacia, and neoplasms. These are just some causes to keep in mind. This is again not an exhaustive list. I am just mentioning some causes in each chief complaint so that you have a little bit of an idea, and this might help you in answering your questions in the viva when your examiner asks you, like, okay, what are the causes of change in voice, or what are the causes of difficulty in breathing? So this will give you a rough idea of it. Third complaint is noisy breathing. Now, here again, the same thing. You ask about the onset of it. Is it gradual or is it a sudden one? How long has it been present for? How is it progressing? Is there any variation, like is there any change throughout the day? Or is there any change with activity, change with posture? Is there any aggravating or relieving factors? Now, noisy breathing can be different types. The two most common ones are stridor or stutter. Now, there is a significant difference in between both of these terms. Stridor is when there is noisy breathing because of an obstruction at the level of larynx, trachea, or bronchi, whereas stutter is more of a low pitched sound which is produced by an obstruction which is above the level of larynx. It usually happens due to vibration of tissues of the pharynx, nasopharynx, and the soft palate. So, this is another important thing that you have to distinguish when a patient comes to you with noisy breathing. You have to determine what is the level of obstruction over here. Now, again, I'll give you a short list about the causes of stridor. Stridor can be at the level of supraglottis, at the level of glottis, or it can be below the level of glottis. Now, again, you can classify it into congenital, infections, trauma, allergy or autoimmune, neoplastic, and neurologic. And these are all the causes. This is something, again, you can learn up and try to remember. So, at the level of supraglottis, congenital cause would be laryngomalacia, an infective cause would be epiglottitis. Intubation can lead to trauma. Sarcoidosis would be an autoimmune disease. Squamous cell carcinoma or squamous cell carcinoma involving the epiglottis is a neoplastic cause, and laryngomalacia is a neurological cause. At the level of glottis, there can be laryngeal web, atrasia, TB laryngitis, laryngeal fractures, hereditary angioedema, which is an allergic cause, recurrent respiratory papillomatosis, which is a malignant cause, and vocal cord paralysis. And below the level of glottis, it can involve the subglottis or the tracheobronchial tree. There can be a vascular ring or a tracheoesophageal fistula. Croup would be the infective cause here, subglottic stenosis, asthma, subglottic hemangioma, and paralysis of respiratory muscles. This is, in rough, a list of the causes of stridor, a classification of it. Next, we move on to the next chief complaint, which is cough. Is the onset sudden or insidious? How long has it been present for? What is the amount of cough? Is it scanty? Is it moderate? Or is it profuse in amount? Is it continuous or intermittent throughout the day or night? Is it dry? What is the type of cough that you are having? Is it dry? Is it wet? Is it blood tinged? And there every cough will have some characteristic features that you could recognize, and that will help you in diagnosing the patient. I'll give you some examples. If there is an exaggerated forced cough with a lot of throat clearing, that usually points towards pharyngeal cough. If there is a dry hoarse cough, it can be because of irritation of the epiglottis and the glottis. Whooping cough is diagnostic of diphtheria. Nocturnal cough can point towards congestive cardiac failure. A cough in the morning will point towards bronchiectasis. A cough which happens after meals, it will have a point towards laryngeal and pharyngeal diverticulum, hiatus hernia, or it can be neurogenic. Cough which gets relieved with sleep, you could think about psychogenic causes here. Cough during the fluid injection, it can happen in tracheoesophageal fistula. Cough with a large quantity of foul smelling sputum, you should immediately think about lung abscess. A paroxysmal and irritating cough, it can be in a recurrent laryngeal nerve lesion due to aspiration or a laryngeal spasm. Suffocating cough will be seen in foreign body larynx and TB laryngitis. Blood tinged sputum will be seen in TB and malignancy. So, these are some characteristic features of cough that you can ask the patient about, and this will help you maybe in pointing towards the right direction. Next, we talk about a little bit about the causes of cough. So, cough can be dry cough or wet cough. And if it is a wet cough, it can have ENT causes or respiratory causes. ENT causes would be sinusitis, aspiration, tracheobronchitis, etc. Respiratory causes could point towards lung abscess, bronchitis, bronchiectasis, pulmonary TB, etc. Next, moving on to dry cough. You can classify this into ENT causes, respiratory causes, cardiac causes, and some miscellaneous causes. Miscellaneous cause would be gastroesophageal reflux disease, where sometimes due to the reflux, you end up having a lot of dry cough, which does not get resolved no matter what kind of cough syrup you are prescribing the patient. In that time, you should be aware, does this patient have any acidity issues? It can point towards laryngopharyngeal reflux disease. Next, the cardiac causes could be mitral stenosis and left ventricular failure. Respiratory causes could be incipient bronchial asthma, pneumonia, pleuritic diseases, mediastinal diseases, sarcoidosis, or malignancy. Now, coming to the ENT causes of dry cough. It could be because of an infection, an inflammation, some paralysis, or because of a mass. In infection, the common causes are acute pharyngitis, acute laryngitis, vocal cord hematoma, fungal infections. Inflammatory causes could be smoking, environmental, allergic causes. Palsy could be because of superior laryngeal nerve palsy. And mass could be benign tumor or malignant tumors of larynx or any external mass that could be compressing on the larynx, like, for example, a laryngocele, a goiter, or any tracheal compression. So, this is all about cough. Next complaint is difficulty in swallowing, also known as dysphagia. So, does this have a sudden onset or an insidious onset? An insidious onset is seen more in malignancy, whereas a sudden onset will be seen in cases of foreign body impaction or impaction of food in a pre existing stricture of esophagus or malignancy, or any neurological disorders like a motor neuron disease. How long has this difficulty been swallowing been present for? Is it gradually progressive or rapidly progressive? Is it continuous throughout the day or is it intermittent? Like, are there spasms or spasmodic episodes over an organic lesion? What is the character in this? Do you have difficulty in swallowing more to liquids or more to solids? Or did it start with solids and slowly progress to liquids? Or does the patient not be able to swallow his own saliva as well? That is known as complete aphasia. So, there is a how does this help you really? If a patient has dysphagia more towards liquids, it can point towards paralytic lesions, neurological lesions, or achalasia cardia. These are the common causes where you see difficulty in swallowing more to liquids than solids. Difficulty in more to solids and then progressing to liquids, this will indicate more towards malignancy of the hypopharynx or the esophagus and a stricture of the esophagus. Intolerance to acidic food or fruit juices. This can be seen in ulcerative lesions. And are there any associative symptoms here? Like, does the patient have regurgitation and heartburn? Then it might point towards hiatus hernia. Is there regurgitation of undigested food when you lie down with cough at night? This will point towards hypopharyngeal diverticulum. Is there any aspiration into lungs? This can point towards laryngeal paralysis, or aspiration into nose, which will point towards palatal paralysis. So these are the things you need to ask when a patient comes to you with difficulty in swallowing. Now I'll discuss about the causes of dysphagia. This is again not a very exhaustive list. This is just to give you a rough classification of how could you classify a case of difficulty in swallowing or dysphagia. It could be classified into organic and non-organic. Non-organic is basically the functional cases, which is also known as globus hystericus. Now, coming to organic cases of dysphagia, this can be divided into extraesophageal and esophageal. Extraesophageal can be again divided into oral, oropharyngeal, or miscellaneous other causes. Oral causes here could be stomatitis, ulcers, cleft palate, Ludwig's angina, carcinoma, palatal palsy. Oropharyngeal causes would involve tonsillitis, quinsy or peritonsillar abscess, foreign body, carcinoma, bulbar palsy, retropharyngeal abscess, parapharyngeal abscess, or Plummer-Vinson syndrome. And other causes here could be trismus, nasal tumor, nasal packing, or maxillofacial trauma. Next, we move on to the esophageal causes. Here, again, it can be divided into two types. One are causes which are in the lumen, also known as luminal causes, and in the wall, the intrinsic causes. And the second one is the outside the wall causes, which is outside of the esophagus, which is extrinsic or extraluminal causes. So, extraluminal causes can be anything which is causing an external compression on the esophagus, for example, by thyroid tumors, pharyngeal pouch, cervical lymph node mets, cervical spondylosis, retrosternal goiter, dysphagia lusoria, which is a developmental anomaly in the anatomy of subclavian artery, mediastinal tumors, cardiomegaly, or pericardial effusion. Whereas luminal and intrinsic causes can be again further classified into congenital neoplastic, infective or inflammatory, traumatic, and neurological causes. So, this is all about the causes of dysphagia. Next, we move on to painful swallowing. I am so sorry, this is supposed to be painful swallowing. Yeah. So, this is odynophagia. Is the sudden onset or is there insidious onset? How long has it been present for? How is it progressing? Is it gradually progressing or is it rapidly progressing? Is there any other associated features like is there any referred pain happening in the ear? And the causes of odynophagia can be divided into inflammatory, ulcerative, foreign body, or laryngeal trauma. Inflammatory causes could be tonsillitis, pharyngitis, quinsy, abscesses at the base of tongue or epiglottis, retropharyngeal abscess. Ulcerative lesions could be aphthous ulcer, tuberculosis, syphilis, foreign body, or laryngeal trauma. Next, we move on to disturbance in the taste. Now, what are the different types of taste disturbance a patient can present to you with? First two types are one is ageusia, which is basically a more or less complete loss of taste sensation, and hypogeusia means there is a decreased taste sensation. And the causes of both of these can be classified into the following. First is diseases that can cause dryness of the buccal mucosa. For example, in Sjogren's syndrome, where the secretions of the salivary glands completely dry out, or radiotherapy of the head and neck, which destroy the salivary glands, Mikulic's disease, or surgical removal of the salivary glands. Second is a heavily coated tongue, where you can see, for example, in candidiasis. Third is a lesion or a destruction of the taste buds on an extensive area by excessive use of alcohol or a burns involving the tongue, any ulceration or malignancy involving the tongue. Fourth one is a lesion of the peripheral fibers of taste sensation. For example, neuritis, infections, toxins like alcohol, arsenic, compression or damage of the glossopharyngeal nerve, damage to facial nerve in Bell's palsy, damage to choroid tympani nerve in middle ear surgery. There can be some vitamin deficiency like vitamin A, vitamin B12, and zinc deficiency. There can be endocrinal disturbances like hypothyroid or Cushing syndrome. There can be drugs like cytotoxic drugs or amitriptyline. It can also be seen in post-coryzal or post-influenzal state, and there can also be central lesions like multiple sclerosis, tumor, abscess, hemorrhage. These are all the causes of ageusia or hypogeusia, which is complete absence or decreased sensation of taste sensation. Next, we come on to hypergeusia. What is hypergeusia? Where there is an exaggeration of the gustatory sensitivity. And the causes can be like occupational, like wine tasters and tea tasters, lesions of the brain, tabes dorsalis, and having infections like typhus fever. Next, we move on to altered speech. Again, you ask about the onset, the duration. What is the character of the altered speech? Now, the character is very important here. For example, if you find a child presenting to you with delayed speech or difficulty in speech, you can look at their frenulum linguae, where you can find a shortened frenulum linguae, which is also known as tongue tie or ankyloglossia. Second, a nasal voice, which is also known as rhinolalia aperta. Here, what happens is an abnormal communication occurs between the buccal and nasal cavity, as a result of which the patient presents with a very nasal voice. This can be seen in palatal paralysis, cleft palate, palatal perforation, or following adenoidectomy in a submucous cleft patient. Third is rhinolalia clausa or incapability of pronouncing nasal nouns. Here, when the patient tries to pronounce M and N, it ends up sounding like B and P. This happens in cases of adenoid hypertrophy and in nasopharyngeal tumors. Next is the muffled voice. I have already spoken about it, the hot potato speech, where what happens is this occurs because of a mechanical obstruction to speech and articulation by tumors within. This will happen in tumors which involve the base of tongue, epiglottis, or the hypopharynx. Next is a thick or guttural voice, which is seen in pharyngeal or peritonsillar abscess. Next is a difficulty in articulation. This is known as dysarthria or anarthria. This happens because of a mechanical difficulty. This can be seen in causes of involving the tongue, like a tumor, abscess, inflammatory lesion, lips or cheek, like a tumor or inflammation, paralysis of peripheral origin, like involving the hypoglossal nerve or the facial nerve, paralysis of central origin, bulbar lesions, or a pseudobulbar syndrome. So, this was all about the major chief complaints that I have mentioned to you. Next, we'll move on to discuss the associated symptoms. And I'll discuss just a little bit about each such symptom. So, the first one is foreign body sensation and throat clearing. This happens because it could be either there's an actual foreign body in there, which is leading to a foreign body sensation, or it could be because of some secretions or tumor which is causing irritation in the throat. So, if you find a foreign body sensation at the base of the tongue, you could suspect lingual thyroiditis or an elongated uvula. A foreign body sensation in the throat can have a lot of causes, like an elongated styloid process. A very common name of a syndrome where you see elongated styloid process is the Eagle syndrome. Next is a gastroesophageal reflux disease, keratosis of tonsil, postnasal drip, Forestier disease, supraglottic malignancy. So, in supraglottic malignancy, foreign body sensation is often the first symptom that the patient comes to you with. It can also be seen in hypopharyngeal malignancy, a foreign body in throat, or granular pharyngitis. If a patient presents to you with foreign body sensation with repeated throat clearing throughout the day, it can point towards chronic laryngitis or any tumors involving the larynx. Second symptom is nasal regurgitation. Nasal regurgitation means whatever you're ingesting, the regurgitation of ingested food into the nose. And this occurs due to inadequacy of the velopharyngeal sphincter, leading to an incomplete closure of nasopharynx and oropharynx. And so, since there is a communication remaining between the oropharynx and nasopharynx, the contents of the oropharynx is entering into the nose. This can be seen in cases of palatal paralysis or any case of abnormal communication between the oral and nasal cavity. Third is disturbed salivation. Now, here you can either have increased salivation or you can have decreased salivation or dryness of mouth. So, increased salivation is also known as stylism. A few causes are like ulcers of the mouth and pharynx, poor orodental hygiene, ill fitting dentures, or iodine therapy. This is a very important cause, iodine therapy. Decreased salivation or dryness of mouth can be seen in mouth breathing, like patients who have adenoid feces and they complain of mouth breathing. You will see that because as a result of breathing through the mouth, their mouth ends up drying up a lot. So they have dryness of mouth. In cases of irradiation, where the salivary glands have been destroyed because of radiation, Sjogren's syndrome, which is an autoimmune disease, dehydration, febrile states, drug induced, or in cases of hypothyroidism. The next associated symptom would be ulceration. Some common ulcers like angular stomatitis, which happens because of nutritional deficiency of the vitamin B complex. Here, what happens, you'll have cracks or fissures at the angle of the mouth. Next, there is aphthous ulcers. Then there is dental ulcers. Dental ulcers are caused by like sharp tooth or ill-fitting dentures or like sharp dentures, and these will usually be seen at the periphery or the undersurface of the tongue. Then there is syphilitic ulcer, where the common characteristic is punched out edges, and undermined edges will point more towards tuberculous ulcer. Post pertussis ulcer, which can be seen in frenulum of tongue in children with whooping cough. And chronic non-specific ulcer is usually painless and it affects the anterior two-thirds of the tongue. Malignant ulcer. Malignant ulcer, the important characteristic here is that initially it is painless, but over time it becomes painful. And this can be associated with an earache or a lymph node enlargement. Next is difficulty in opening mouth, also known as trismus. Now, when you are asking the patient about difficulty in opening mouth, you should first know what is the normal amount of opening of mouth. Normal amount is 5 to 7 centimeter. Anything less than that will be classified under trismus. Now, how do you grade trismus? Grade 1 is when there is 2.5 to 4 centimeter of mouth opening. Grade 2 is when there is 1 to 2.5 centimeter of mouth opening. Grade 3 is when there is less than 1 centimeter of mouth opening, and grade 4 is total trismus. So, it is very important to know about the mouth opening because if you are planning surgery for a patient, it most if this the case is through general anesthesia, usually the patient is intubated through the mouth. That is information which would be very critical in planning the case. So, I'll discuss a little bit about the causes of trismus. It could be because of abnormalities of teeth or mandible, acute inflammation in the TMJ region, trauma, muscle spasms, tumors, and miscellaneous causes. So, abnormalities of teeth or mandible could be like unerupted tooth, stomatitis, osteomyelitis of the jaw, osteoarthritis. Acute inflammation could be abscesses like peritonsillar abscess or peritonsillitis, sialadenitis, otitis externa, malignant otitis externa. Traumatic causes like fractures involving the temporomandibular joint, the zygoma, the mandible, There could be a dislocation of the temporomandibular joint, or any scar which can lead to fibrosis and adhesion, as a result of which now there is difficulty in opening mouth. Could be muscle spasms because of epilepsy, meningitis, tetany, some tumors, and other causes like ankylosis of the temporomandibular joint. Next, we move on to bad breath, also known as halitosis. This is more commonly seen in infected tonsils, chronic sinusitis, malignancy, cases of poor orodental hygiene, and dental caries. Next associated symptom is mouth breathing and snoring. It is most commonly seen in cases of adenoid hypertrophy, where ultimately you plan the patient for an adenoidectomy, or a grade 3 or 4 tonsils, or a malignancy of nasal cavity and nasopharynx. Next feature here is hearing loss. Now, you might be wondering, why am I talking about hearing loss in a case of the throat? So here, what happens is sometimes there could be a mass in the oropharynx, where it is extending so much into the nasopharynx that it ends up, that in the lateral wall of nasopharynx, the eustachian tube opens into it. So if the mass extends to this opening, it can block the eustachian tube and lead to eustachian tube dysfunction. And as a result of this, the patient will end up having conductive hearing loss. And you could see the same in adenoid hypertrophy, in cases of cleft palate, in cases of recurrent tonsillitis, or in carcinoma or nasopharynx. These are the causes of hearing loss in a throat case. Now, if a patient comes to you with a lump in the throat, it can be seen in malignancy, a spasm of the cricopharyngeal sphincter, cervical spondylosis, or pharyngeal pouch. A lump in the neck, the first important diagnosis here would be cervical lymph node involvement. And this will point towards a malignancy somewhere else in the throat or the body, where the cervical lymph nodes get involved secondarily. It could also indicate an extension of the laryngeal growth into the neck. It can also indicate a laryngocele. Next is a paresthesia or anesthesia of an area of a chin which is lateral to the midline. This will indicate an invasion of the inferior alveolar nerve by a tumor. Last of all, there can be a swelling, which this swelling, if there's a swelling in any part of the oral cavity or the neck or the larynx or the throat, you have to describe in details about the swelling. And it is very hard to have this discussion within this video, but that's something I can discuss about in a separate video, how to describe a swelling. So these were all the associated symptoms that can happen. And there are some additional other complaints that you have to ask your patient. For example, is there any history of fever? If you see there's an evening rise of temperature history given by the patient, it can help you point towards TB. Or are there history of night sweats, history of weakness of voice? You can see weakness of voice in cases of TB again. Is there a history of vocal abuse? Is there a history of neck trauma, neck surgeries, surgeries under general anesthesia? Why is this important? And this is important because in surgeries under general anesthesia, intubation is usually done through the oral route. In this, sometimes there can end up be an iatrogenic damage to the vocal cords or temporary damage. So this can help you understand if there has been any intubation before. Any history of radiotherapy, history of chest pain, choking episodes, weight loss, loss of appetite, these two features will always point towards malignancy. Or is any history of earache, where there's a referred pain in ear. I have made a separate video on the causes of referred pain in ear, where can the causes originate from. So this was all about the chief complaints and the history of present illness, all the extensive list of what all things you should be asking your patient. Next, we will talk about past history. You should ask the patient about, is there any history of similar complaints in the past, because such complaints will help in diagnosis in a lot of cases. Like for example, before you decide to do tonsillectomy in a case of chronic tonsillitis, you have to first see how many episodes your patient has had before, or cases of adenoiditis, there are history of similar complaints, or a history of carcinoma. There can be recurrent carcinoma. Then you ask her about a history of pulmonary TB, syphilis, diabetes mellitus, hypertension, any history of epilepsy, bleeding disorder, dental caries, any surgical history or other medical history, if there any history of allergic drug history. This is all about the past history. And in family history, you ask about diabetes, hypertension, any similar complaints in the family, like, for example, malignancy. You could find patients of malignancy having in being there in the family itself. Next, you move on to treatment history. Treatment history, you asked whether the same condition has been there for a while. Any has there any treatment been given to it? What medications have been given and how long have they used it? Has there been any relief in the symptoms when they have used these medications? Next is personal history, where you ask about the diet and appetite of the patient, whether the patient sleeps well, is there any history of weight loss? Weight loss and low appetite will point towards malignancy, and about the bladder and bowel habits. And lastly, you ask about the addiction history of the patient. This is very, very important in cases of malignancy. There can be a history of smoking. Whenever a patient gives you a history of smoking, you need to calculate in pack years. And how do you calculate this? This is calculated by multiplying the number of packs of cigarettes which is smoked per day by the number of years that the person has been smoking. So, one pack year is equal to smoking 20 cigarettes. 20 cigarettes is one pack per day for 1 year. And if there is any history of alcohol, what kind of alcohol does the patient take, and what is the usual amount that he drinks every day, and how long has he been drinking for? All of this will help you in determining what could be the diagnosis of your patient. So, this is all about the history taking in a case of oral cavity, larynx, and pharynx. If you have any doubts or any question, you could write it down in the comment section and I'll get back to you. Thank you.